So welcome back on this third video about anesthesia consideration in patient needing emergent XLAP. So this last video would be about White the cat that needs to be anesthetized because he's got a uroabdomen. So this patient has come to you and he's 12 years old, cross-Siamese, male-neutered, and he was fine with lethargy and vomiting. And then the owner is reporting that the patient had strong urea and hematuria. On the clinical exam, his mucous membrane are pale and tacky, and his CRT is prolonged. His heart rate and pulse rate are 120 beats per minute, so abnormally low, and the pulse is synchronous but weak. On the chest auscultation, there is nothing else to report. Respiratory rate, the respiratory rate is increased, and there is no abnormality on the chest auscultation of the lung field. The rectal temperature is normal, but the patient is collapsed, and he scored 5 after 24 on the Grommer scale, which means that he needs analgesia intervention points. On the abdominal palpation, he's got a distended turgid bladder, and in the history, there is no change in water or food intake. He's also have history of vomiting. So what question comes to your mind, I'm sure, is like, should I do further analysis? Do I need to postpone the procedure being ureterostomy? Do I need to start fluid therapy before the GA? Can I give non-steroidal for analgesia purposes? And what are the anesthetic risks? So before I continue moving on, there is also a video made by Lee Min-kin and Chris Munda about medical and surgical management of uroabdomen and blocked bladder. So what to do? So first, should I do further analysis? Yes, definitely. You want to do a biochemistry and hematology, and you want to know the electrolytes because those patients have a higher risk of hyperkalemia, which is what I'm suspecting on the clinical exam because the heart rate is low. You also want to measure the blood pressure because this patient is very sick, and then maintaining the blood pressure in those patients are essential to maintain perfusion of the kidney. So you do a biochemistry and you found that the creatinine and the urea are very high, and also that the potassium is very elevated. So you found that this patient had moderate azotemia with a mild hyperkalemia. So do I need to postpone the procedure? No, because if you want to fix the problem, you need to unblock this cat. It's not going to get better if you're not doing anything at this stage. So do I need to start fluid therapy before the GA? Yes, definitely, between 3 to 4 mL per kilo per hour. You probably won't be able to fix the actual AKI that he's demonstrating, but you want to readdress if he's got evidence of dehydration. Can I give non-steroidal? Definitely no. Definitely not until the azotemia is resolved and he's eating and drinking. So you probably would be able to provide non-steroidal maybe a week or two after this is resolved. But even so, I would advise not to for the moment. So let's go ahead with the surgery. So let's think about the consideration and the anesthesia plan. So we'll start with the patient. So the patient is at risk of hypothermia because he's a small patient, it's a cat. So you want to think about pre-warming the patient. To pre-warm the patient, you can use a heat mat or a bear hugger. And you can also consider using conservative fresh gas flow. So if you have a capnograph monitoring, you use a non-rebreathing system, you can start your fresh gas flow as high as normal, which is usually advised for TP Sarbanes between 2.5 to 3 times the minute volume, and then titrate down the fresh gas flow until you have some evidence of rebreathing. So that would help you to reduce the evaporation experienced by the patient during the GA. In terms of pathology, so this patient has a urinary obstruction, so there is a risk of abdominal pain, and he's hypokalemic, so he's at risk of being bradycardic. He's got azotemia, so they might have nausea and have aspiration pneumonia. He's got evidence of AKI as well. So the choice of drugs need to be that they maintain or don't at least decrease the glomerular filtration rates. You want to not go higher or decrease the potassium concentration of this patient, and you want to use multimodal analgesia. Again, a little reminder: when you treat pain, you want to treat the actual pain, but also preempt and prevent the pain that the patient is going to sustain during the surgery, but also after the surgery. So in terms of procedure, so obviously exploratory laparotomy are painful, and there's always a risk of bleeding. And this patient also is at risk of hypothermia because we enter an internal cavity. So pain, choice of drugs, as we said before, you want to provide analgesia, but also multimodal analgesia. So in terms of consideration, if we organize them, so the main one is the kidney disease and the bradyarrhythmia that this patient might experience, pain, obviously, and a little risk of bleeding, and the risk of hypothermia. So drug to avoid on this patient is definitely ketamine, because cats don't metabolize ketamine through the liver, but through the kidney. So if they have a kidney disease, that's when they can't treat properly, so they might sleep forever. And dexmedetomidine, because it affects the level of potassium, and she's already hyperkalemic, so there is a risk of further increasing the hyperkalemia if you give dexmedetomidine. Also, it's a diuretic, so if the bladder is full, you maybe don't want to make it fuller. So you can pre-med the patient with just methadone, 0.3 mg per kilo, and pre-warm the patient. You want also to do a head-up induction because, as we said before, he might be nauseous. He's got evidence of vomiting, so you want to reduce the risk of aspiration. Induction, you can use a co-induction with alfaxone or propofol and midazolam, and then top up with alfaxone or propofol if you need to. And in terms of maintenance, you can use either SIBO or isoflurane. If you can, giving an epidural with morphine at between 0.1 and 0.3 mg per kilo would be very beneficial, specifically for the postoperative analgesia. And then continue with Hartmann 3 to 4 mg per kilo per hour. So again, in terms of monitoring, mean arterial pressure and Doppler are essential, as well as heart rate, respiratory rate, and temperature in those patients. Monitoring the SpQ would be advised, as well as having an ECG because of the risk of bradyarrhythmia. And the ECG could be very interesting in terms of preempting if the patient have hyperkalemia, because the T wave might change in morphology. So if you have an ECG, by all means, put it on. So what can go wrong in those patients? They can be painful. So again, giving a boluses of methadone between 0.1 to 0.3 mg per kilo. So you don't want to give a bolus of more than 0.1 mg per kilo, but you can go up to 0.5 mg per kilo for 4 hours of methadone. You can also give boluses of fentanyl. Well, after you gave those drugs, the patient might stop breathing. So you might consider either decrease the inhalant or hand ventilate if you don't have a ventilator. This patient is at very high risk of bradycardia because of the risk of hypercalcemia. So if it's happened and you suspect hyperkalemia, so do check the electrolytes. And if they are bradycardic because of hyperkalemia, then you can give a bolus of calcium that would be help to stabilize for about an hour the membrane of the myocardocytes. It won't fix the hyperkalemia. It would just have counteract the effect of the hyperkalemia. And if you want to stabilize hyperkalemia, you can use insulin and glucose CRI. But I'll send you back to the lecture from Chris Monda on this aspect because she's describing it very well. If the patient is bradycardic but not related to hyperkalemia, which can happen in cats specifically, then you can give glycopyrrolate 10 microgram per kilo IV. Now, glycopyrrolate doesn't work if the patient is hypothermic. Hence, you want to maintain the patient at appropriate temperature. Cats can also become bradycardic because they are hypovolemic. So if you suspect they are hypovolemic, then you can give a fluid bolus to see if it's changed the blood pressure. So typically what you would see is that your patient is bradycardic and hypertensive, and then you give a fluid bolus and the heart rate increase as well as the blood pressure. So if you're not so sure why the patient is hypertensive, is it because he's bradycardic or if it's because behind on fluids, giving a fluid bolus to start with before you give the glycopyrrolate would help. So if they're hypertensive, as I said before, either the different bradycardia treatment or decreasing halon agent, or giving fluid boluses as needed, as we discussed earlier. Obviously, cats are more likely to become fluid overloaded, so be careful on how much fluid you're giving. So typically start by 1, and then if it's responsive, you can repeat it once. Now, if the patient has cardiac disease, you want to be a bit more cautious, and then instead of giving 10 ml per kilo over 10 minutes, start by mini bolus, such as 5 ml per kilo over 5 minutes. If those doesn't work, then you can consider giving boluses of ephedrine between 2.1 to 2.2 mg per kilo to effect. So you can give 1 or 2 boluses or until they stop working. Now, they might have bad recovery, so because they might be painful or disorientated. So in those situations, you can also consider giving propofol 1 to 2 mg per kilo IV. So that's it for those 2 cases. You would find in the feed the link for 2 PDF that are summarizing those 2 cases. Thank you very much for listening.